festivities to all of you joining from across the country and other parts of the world. I am Ashish Shah, representing Intas Pharmaceuticals Limited. And happy Makar Sankranti, happy Bihu, happy Lohri, and happy Pongal to all of you. Let us uh, celebrate these festivals together, and these festivals bring prosperity, happiness, and good health to all of us. Then now it's time to go academic. Uh, Today's topic is clinically relevant update on lymphomas and under the aegis of Mumbai Hematology Group and supported by Intas Oncology. We are grateful to Professor Dr. M.B. Agarwal sir, who is the program director for this webinar, and he has been the man behind the longest running educational initiative in the field of hemato-oncology. I think it started almost 4 years ago, and we would have crossed, sir would have crossed 400 plus webinars every Saturday and Sundays, relentlessly, with an objective that yes, everyone in the country, and not in the country but other parts of the world, are educated about the latest in the field of hemato-oncology. Thank you so much, sir, for the selfless uh, efforts. Dr. Amit Khurana, sir, he comes from Surat, and he's highly skilled and experienced hemato-oncologist with decade of experience. And he always keeps himself updated about everything in the field of hemato-oncology, BMT, if not through the physical mode, but also through the virtual mode. Sir would take us to today's webinar. So over to you, sir.
Thank you, Mr. Ashish. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Brad Carl from St. Louis, USA, and he's going to lecture us on clinically relevant updates on lymphomas. This webinar is brought to you by Mumbai Hematology Group, supported by Intas and managed by Perfect Square. I thank Dr. Manoj Kumar and the team Intas, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Brad Carl from St. Louis, USA, all our discussants who are themselves very eminent hematologists and hemato-oncologists, and you participants for sparing your Saturday evening, morning, and afternoon. Tomorrow, that is Sunday, 14th of January 2024, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on immunosuppression and hepatitis B and hepatitis C by our own guest speaker, Dr. Abha Nagral from Jaslok Hospital and Research Center, Mumbai. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Ami Patel from Blood and Cancer Institute, Surat, Dr. Amrita Chakrabarti from Max Hospital, Delhi, Dr. Anushri Chaturvedi from Advanced Cancer Center, Sundarpur, Varanasi, Dr. Dinesh Burani from Rajiv Gandhi Cancer Institute Research Center, New Delhi, Dr. Gaurav Prakash from PGI, Chandigarh, Dr. Hasmukh Balar from Blood and Cancer Institute, Surat, Dr. Kartik Purohit from Zydus Hospital, Vadodara, Dr. Kunal Goyal from ACTRAC, Mumbai, Colonel Dr. Kundan Mishra from Command Hospital, Lucknow, Dr. Mitesh Halwawala from Kashi Plaza, Majura Gate, Surat, Dr. Mithun Abram Prakash from Christian Medical College, Vellore, Dr. Narendra Agarwal from Rajiv Gandhi Cancer Institute, New Delhi, Dr. Nitin Gupta from Sir Gangaram Hospital, Delhi, Colonel Dr. P. Suresh from RNR Army Hospital, Delhi, Dr. Pavan Kumar Singh from BLK Max Super Specialty Hospital, Delhi, Dr. Reena Nair from Tata Medical Center, Kolkata, Dr. Sushil Selvarajan from Christian Medical College, Vellore. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Brad Carl from St. Louis, USA. Dr. Brad Kahl is Professor of Medicine and Director of the Lymphoma Program at Washington University School of Medicine at St. Louis, USA. He earned his medical degree from Tufts University School of Medicine, Boston. He then completed a residency in internal medicine and a fellowship in hematology at the University of Wisconsin. His research focuses on improving outcomes for patients with lymphoma through testing novel agents in well-designed clinical trials. He's a chair of the ECOG-ACRIN Lymphoma Committee since 2009, where he has facilitated the development of multiple large clinical trials. He helped successfully renew an ECOG scientific operations grant and led a successful effort to obtain a National Clinical Trials Network Lead Academic Performance Site Award for University of Wisconsin. He is a Washington University principal investigator for the LEO Consortium, a large molecular epidemiology effort funded by NCI. He is a member of several professional societies, including ASH, ASCO, ECOG-ACRIN, US FDA Oncologic Drug Advisory Committee, and NCI Lymphoma Steering Committee. He is a member of Lymphoma Research Foundation Scientific Advisory Board and has served as chair of the LRF Mantle Cell Lymphoma Consortium from 2012 to 2018. And today he's with us and is going to lecture us on clinically relevant update on lymphomas. Well, thank you so much. Over to you, Professor Brad Kahl.
Thank you for the kind introduction. I'm going to share my slides now. Hopefully everybody can see them okay.
Yes, sir.
So I was asked to provide updates from the 2023 American Society of Hematology meeting. And so I picked what I thought were the most interesting presentations in lymphoma. And I also included a couple of presentations in chronic lymphocytic leukemia. So I'll start with some abstracts in follicular lymphoma. There were a couple of abstracts that provided longer-term follow-up on bispecific monoclonal antibodies. I think you'll see it's sort of a theme throughout the presentation today that bispecifics are really the newest, most interesting thing in lymphoma in the last couple of years. And at the meeting, we saw some new data and mostly updates of previously presented data. But it's very important to get the long-term follow-up from some of these studies so we have a better sense of the durability of these responses. So I'm going to start with the 3-year follow-up of mosunetuzumab. Mosunetuzumab is a bispecific monoclonal antibody that targets CD20 and CD3, and it was approved in the United States just over a year ago for relapsed refractory follicular lymphoma for patients who had failed at least 2 prior systemic therapies. And this was based on a single-arm study, but what we saw at the meeting was longer-term follow-up with a median follow-up time now of 37 months. Just to remind you of the mosunetuzumab dosing strategy, like all the bispecifics, it uses a stepped-up dosing strategy, and that's to help mitigate the risk of cytokine release syndrome. So patients receive a very small dose of 1 milligram on day 1 and another very small dose of 2 milligrams on day 8. And then they receive their first full dose of 60 milligrams on day 15 of cycle 1. And then they come back a week later to get another dose of 60 milligrams. And then the drug is administered every 3 weeks, and the dose drops to 30 milligrams. And if patients achieve a CR, complete remission, after cycle 8, therapy stops. And if they're only in a partial remission, then you complete 17 cycles of treatment. So here's the curves with 36-month follow-up. And I was very happy to see the stability of the curves. You can see the patients between 2 and 3 years are generally holding their remissions. And what was amazing is they compared the curve from a year ago to now, and it really hasn't changed at all. So this is duration of response. So this is the curve in responding patients, but you can see that over half of the responding patients are still maintaining their remission at 2 and 3 years, which I thought was impressive durability. And then they separated the responses by complete response versus partial response. And what you can see here, and this seems to be true for all the bispecifics, is that partial remissions don't last very long at all, but the complete responses do have the potential for significant durability. Another new piece of data that was shown, which I thought was nice to see, is how potent they are at depleting B cells from the blood. And then you start to get some handle on B cell recovery. So this is what you can see here is patients don't really start recovering their B cells until 12 months after stopping the therapy. So that's, a year and a half or 2 years with no B cells, which can result in problems with infections. And it's one of the reasons I like mosunetuzumab, because it's fixed duration therapy. So at least the therapy ends at some point, which will allow patients at least the potential to recover their B cells, whereas some of the bispecifics are given indefinitely. And I worry about the very prolonged B cell depletion strategy. So this just kind of summarizes the 3 bispecifics that are the most developed in follicular lymphoma: mosunetuzumab, odronextamab, and epcoritamab, with some of the updated data included in this table from odronextamab and epcoritamab. And like I mentioned, mosunetuzumab is fixed duration. Odronextamab is given intravenously, but given indefinitely. Epcoritamab is given subcutaneously, but also given indefinitely. And they're pretty similar in terms of the risk for grade 3-4 AEs, the risk for cytokine release syndrome, which is common, but unfortunately it's usually mild with these bispecifics. And the need for steroids or tocilizumab is not terribly common. You can see the overall response rate and complete response rate data for the 3 drugs is pretty similar. 78% overall response rate, 60% complete response rate for mosunetuzumab, and odronextamab and epcoritamab are not much different than that. Mosunetuzumab has longer follow-up in its study now because we just saw 3-year data. Odronextamab and epcoritamab, not quite as long, but I think I have the curves here next. Here's odronextamab with 19 months of follow-up. Here's epcoritamab with 17 months of follow-up. And then here's the mosunetuzumab curves that I just saw you. So I'm sort of doing cross-trial comparisons right now, which is never really fair. But they look similar, although the odronextamab curve seems to be dropping a little bit more abruptly than the mosun curve and maybe the epcoritamab curve. So we'll have to see how this data matures over time, but that's 3 promising new drugs in follicular lymphoma. And then we saw a couple of longer term updates for CAR T-cell lymphoma and CAR T-cell in follicular lymphoma. We have 3 CAR T-cell products in the clinic in follicular lymphoma in the United States. Axi-cel and Tisa-cel are both approved. And I think we're expecting Lysa-cel to get an approval sometime in 2024. So I think we'll have 3 commercially available at some point this year. And this just shows the different constructs. So for Tisa-cel, we saw longer term follow-up from the ALARA trial. We can see at 24 months, 57% of patients are still in remission. So that's good. I'll be really anxious to see 3-year follow-up, 4-year follow-up, 5-year follow-up, because it's hard to know what to tell patients to expect right now in terms of durability from these products, because we just don't have 3, 4, 5-year follow-up. But at 2 years, the majority of patients who receive T-cell are still holding their remission. So that's good. And then this was the Lysocell data that was shown at ASH. And again, very impressive progression-free survival curves, but the follow-up is very short here. Look, this is 12 months, and hardly any patients are even out to 24 months. So it looks good early, but for Lysocell, we really need longer follow-up. I'm assuming it's going to look as good as T-cell and Axi-cell, but we need to see the longer-term data. But response rates are high, and at 12 months, the durability looks excellent. So this is just sort of my attempt to summarize what we know about the different CAR T products in follicular lymphoma. Oops, sorry about that. In the single-arm trials that were conducted, you can see the overall response rates, generally in the 85 to 95% range, with complete responses in the 70 to 90% range. And here's what we know about durability. Axi-cell, at 3 years, over half of patients are still in remission. T-cell at 2 years, over half of patients are still in remission. And Lysocell, we just have 12-month data at this point, but it looks great. Definitely more toxicity with Axi-cell, more CRS and more ICANS. The T-cell and the Lysocell products look to me like they're going to have better safety profiles in follicular lymphoma. We find ourselves using Axi-cell a lot in diffuse large B-cell lymphoma. They really have the manufacturing down, and there is more toxicity, but it's very active. But I think for follicular, I think T-cell and Lysocell may turn out to be the preferred products because of the better safety profile. And even though they take a little longer on manufacturing, you usually have time in follicular lymphoma for that little bit of delay. So like I mentioned, Axi-cell, T-cell are both approved in the United States, and we think Lysocell will get approval at some point this year. Okay, I'll shift gears and show a couple of things that were shown in aggressive B-cell lymphomas at ASH. This was a presentation from Loretta Nostapil at MD Anderson, and she looked in a very large database just to see how novel therapies were performing compared against chemoimmunotherapy for patients with relapsed diffuse large B-cell lymphoma. So there's this large consortium called the LEO database, and she used that database to pull these patients out. She looked at patients treated with a chemoimmunotherapy regimen in second line plus, and ended up with a cohort of 650 patients, and then looked at patients treated with different types of novel agents that are approved as part of now standard of care. These numbers are smaller, but the novel therapy cohort was 174 patients, and it ended up being 116 patients treated with polatuzumab vedotin-based regimens, 55 patients treated with tafasitamab-based regimens, and then 42 patients treated with loncastuximab tesirine regimens. So how did they perform? Oh, this is just sort of the patient characteristics. And you can see they're pretty similar, although the TAFA patients are a little bit older. And the patients who received novel agents were more likely to have had prior CAR T-cell therapy compared to the patients who received chemoimmunotherapy. So kind of a little bit sobering data, depressing here. Here's the response rates for chemoimmunotherapy and relapsed large cell lymphoma. Only 34% overall response rate, not very good. Here's POLA-based regimens, 42%, a little better, but still not that great. Even more disappointing, tafasitamab-based regimens, overall response rate only 25%, and then Lanka only 40% overall response rate. And then she also broke it down by prior CAR. These numbers get a lot smaller, so I'm not sure how reliable these estimates are, but overall, all of these are not impressive. And look at the curves for the 4 different approaches. You see just, rapid drop off with medians probably in the 6-month range or less. And if you separate it out by prior CAR, maybe Tafa and Lanka performed a little better, but really it just shows how much need there is for better treatments in relapsed and refractory diffuse large B-cell lymphoma. Here's the overall survival. So hopefully we're getting better options in relapsed diffuse large B-cell lymphoma. And so here's going back to bispecifics. Here was a really interesting study from the LYSA group in France, looking at glofitamab as a single agent in patients with relapsed diffuse large B-cell lymphoma after failing CAR therapy. So this would be a high-risk population. And one of the interesting things about this trial is they accelerated the stepped-up dosing strategy. They had looked at a database and showed the really poor historical outcomes for patients failing CAR with a median overall survival of only 5 months. So here's the traditional glofitamab dosing in this box up here. Patients receive a dose of obinutuzumab on day 1, and then they receive a very small dose of glofitamab on day 8, and then another small dose of glofitamab on day 15. So you don't get to your first full dose of glofitamab until cycle 2, day 1. So that takes 3 weeks to get to your first full dose of glofitamab. And some patients with diffuse large B-cell lymphoma can't wait that long because of the aggressiveness of their disease. So in this study, they really compressed the ramp-up schedule. So patients would receive the obinutuzumab dose on day -3, the first glofitamab dose on day 1, and then the next glofitamab dose on day 3. So they're up to the first full dose on day 8 of cycle 1. And then you're up to full dose for the duration. And their study met its primary endpoint of improving the overall survival. The overall survival in this cohort of patients receiving glofitamab after CAR T-cell failure was 17.6 months versus their historical comparison, which was much less than that. The response rate for glofitamab in this population was 65%, with 36% being complete metabolic responses. And you can see that if you were one of those lucky patients who got a complete metabolic response, there's pretty good durability at 12 months for those patients. So this just looks at the dose intensity of the different strategies and the time to the first full dose glofitamab infusion. And, they really compress it and get the glofitamab in a lot faster. And they made the point that there were no progression events observed within the first 2 cycles. So, I thought this was really innovative on their part and a neat strategy to get the glofitamab up to full dose quicker. And then staying, on the bispecific theme, we did see the final analysis of the ELM-2 study. So this is the bispecific monoclonal antibody odronextamab in patients with relapsed refractory diffuse large B-cell lymphoma. So it has the same sort of physical properties as other bispecifics, bind CD20, bind CD3. And odronextamab also has a a stepped up dosing strategy to mitigate the risk of CRS. It has to be given on days 1 and 2, and then 8 and 9, and then 15 and 16 in cycle 1. And then when you get to cycle 2, then you get to the full dose of 160 milligrams, and then it's given weekly in cycles 2 through 4, and then it's given every other week after cycle 5. So a very different dosing strategy. So here are the curves. I was a little disappointed. The median progression-free survival is only 4 months, and that plateau here looks lower to me. We're down in the 24-month progression-free survival rate is 21%. To me, this doesn't look quite as good as, say, glofitamab looks in diffuse large B-cell lymphoma. Certainly, if the patient achieves a complete response, there's more potential for durability, so that's good. But I think we've been using glofitamab, and I don't really see myself changing to this. This has a more complicated ramp-up schedule. The patient has to come more often for treatment. There's no end date to the treatments, whereas glofitamab stops, and then the longer-term data doesn't look quite as good. So it was very helpful for me to see this, and I'm sure this will be a useful product in some settings, but I'm not sure it's going to be quite as active as glofitamab. Here's the safety. Most patients get some cytokine release syndrome. Fortunately, it's usually mild, grade 1 or 2. But for the most part, these bispecifics are well tolerated. You did see me talk about prolonged B-cell depletion, and there were, a modest number of infectious deaths, some due to COVID or other infections. But that is something that you just have to be really aware of. These bispecifics are very, very potent B-cell depleting agents, and the B-cell depletion can be prolonged, and this can lead to more risk for serious infections. Okay, I'm going to switch gears now and talk about mantle cell lymphoma, and there were a couple of abstracts that I thought were worth sharing. So this one was really interesting. This was presented by Anita Kumar from Memorial Sloan Kettering, and we've known now for a few years that patients with mantle cell lymphoma that have p53 mutations are incredibly difficult to manage, and traditional immunochemotherapy works very poorly, including auto stem cell transplant. And so extrapolating from our experience in CLL, there was a lot of interest in using more novel agent type strategies in these p53 mutated patients. So I think this is the first time I've ever seen a series of patients with p53 mutated disease treated with a regimen. And so this was really interesting to see. The regimen here is called Bovin. So it uses 3 novel agents: zanubrutinib, BTK inhibitor zanubrutinib, combined with obinutuzumab, the anti-CD20 monoclonal antibody. The obinutuzumab goes for 8 cycles and then stops. The zanubrutinib is given for at least 2 years. And then after 2 months, venetoclax is introduced. I think they delayed the venetoclax so they didn't have to deal with tumor lysis risk. Their approach in this, trial was to stop treatment after 2 years for patients who were in a MRD negative CR. And if the patients didn't achieve a deep remission, then they just continued on therapy. And the primary endpoint is a 2-year progression-free survival. So this is a small study, but it's, like I said, it's the first time I'd seen a series of patients with p53 mutant mantle cell lymphoma. So they had 25 patients in the series. And it was nice to see the description. There's a variety of morphologies, classical, blastoid, pleomorphic, big range of Ki-67. Most of the patients were high risk by MIPI. So the response rates were very impressive, 96% overall, with 88% being complete remissions. And the 2-year progression-free survival is 72%, which is way better than any historical look at p53 mutated mantle cell, where the curves just go straight down with chemotherapy. So I thought the data looked very encouraging for this high-risk patient population. And I think, this is a strategy that we're interested in developing further in the United States. And then the other mantle cell trial that I thought was worth sharing was the late-breaking abstract Simpatico. This was probably the only potentially practice-changing lymphoma trial I saw at ASH. Most of the ASH lymphoma presentations this year were studies that were really early or just long-term follow-up. And this was the only new, one of the only new randomized clinical trials that I thought could influence practice. So this was a global study in relapsed mantle cell lymphoma. And it was comparing ibrutinib to ibrutinib plus venetoclax. And the venetoclax was included for 2 years and then stopped, and then the patients would stay on single agent ibrutinib. And again, these patients were relapsed mantle cell lymphoma, 1 to 5 prior lines of therapy. And the primary endpoint is progression-free survival. So we ended up with about 134 patients in each arm. And here are the disease characteristics. And I think it's a pretty typical relapsed refractory mantle cell lymphoma population, median age in the late 60s, about a third of patients having mutated p53. So here's really the bottom line from Simpatico. The orange curve here is single agent ibrutinib, and the blue curve is the combination of ibrutinib venetoclax, and you can see the median progression-free survival improved from 22 months to 32 months. So reasonably impressive improvement in progression-free survival with the addition of venetoclax. That benefit seemed to hold no matter what the patient subtype was. No difference in overall survival, but the complete response rate, duration of response, and progression-free survival improved with the addition of venetoclax. So then you have to decide, is it worth the added toxicity? There's definitely more toxicity with ibrutinib ven compared to ibrutinib placebo. You can see there's more GI, there's more diarrhea, there's more neutropenia, there's a little more nausea. So I think if this gets like regulatory approval in the United States, I would be inclined to try it. If I had a patient who just had intolerance when the venetoclax is added, I'd probably just drop it. Like, let's say they had too much diarrhea or too much neutropenia or too much nausea. But if the patient was tolerating it nicely, I think I would be inclined to try the 2 targeted agents over the 1, given how difficult it can be to manage relapsed mantle cell lymphoma. And if you can get an extra year or 2 of remission duration without too much added toxicity, that seems worth it. Okay, so I'm going to switch gears now and just talk about CLL for a minute. This is an interesting trial from the group in the UK, sort of sticking with our theme of ibrutinib plus venetoclax. This was a study called FLAIR. This was published in the New England Journal of Medicine, pretty much simultaneously with the presentation. So you might have seen this paper already. This was a phase 3 trial in frontline CLL for younger patients. And the comparison was ibrutinib venetoclax versus the FCR regimen. And what was interesting was it was MRD-based duration of therapy. So if the patient achieves MRD negativity at 1 year, then they take the ibrutinib ven for another year for a total of 2 years. If it takes 2 years to get to MRD negativity, then you continue the 2 drugs for another 2 years. So then you take it for 4 years before you stop. And if it takes you 3 years to get to MRD negativity, then you complete the I plus V for 6 years. So patients were either on I plus V for 2 years, 4 years, or 6 years. And then that was compared to just standard 6 doses of FCR. And you can see the response rates are, very high with both strategies, but the complete response rate and overall response rate with I plus V is over 90%. So that's impressive. What was a little surprising was the patients with unmutated disease, which usually performs worse, they were more likely to get to MRD negativity more quickly than the mutated patients. So that was a bit of a surprise to me, but that's what the data showed. And then here's the curves for the primary endpoint of progression-free survival. You can see I plus V. This is 48 months down here. So this is 4 years. I mean, look at that. That curve is above 90% progression-free at 4 years. That is an amazingly good result. FCR performed really well, like it normally does, but this is very impressive progression-free survival curve for a 2-drug novel combination, given in a creative way where you're using MRD to help determine when you can stop therapy. Here's the overall survival, and there is a small but statistically significant improvement in overall survival for ibrutinib plus venetoclax over FCR. So if you give a patient time-limited combination therapy in CLL, what happens when they relapse? So I'm showing this study because it's starting to address that question. This was a trial that was similar to FLAIR called Captivate, where MRD assessments were used to figure out when to stop combination novel therapy. And then in this analysis shown at ASH, they wanted to look at patients who relapsed after their fixed duration therapy and what happened to them. And so there were 53 patients with progression of disease that were monitored. And of those, not everyone had needed second-line treatment yet, but of the ones who did, 21 patients were treated with just single-agent ibrutinib, and you can see the response rates look great, just like you would expect any patient treated with single-agent ibrutinib. And then 6 patients received ibrutinib plus venetoclax. So it's a small sample here, but it is reassuring that if you give, like ibrutinib venetoclax for some time-limited therapy, like 1 year or 2 years, and then you stop, and then your patient goes 3, 4, 5 years, and then they relapse, it looks like you can easily go back to, say, ibrutinib and administer that, and you can expect really good response rates with second-line therapy. Okay, so I'm going to show 2 more abstracts, and then I'll just open it up for questions. And these are 2 presentations in T-cell lymphoma with novel agents. So I thought these were both interesting and pretty impressive. The first is a single-arm phase 2 study of valmetastat, an EZH2 inhibitor, in patients with relapsed refractory T-cell lymphoma. So it turns out that EZH2 mutations are rare in peripheral T-cell lymphoma, but EZH2 overexpression is common. And that's the biologic rationale for trying an EZH2 inhibitor. Valmetastat is actually a dual inhibitor of both EZH2 and EZH1 and results in epigenetic regulation, which could result in anti-tumor activity. It's approved in Japan for relapse refractory ATLL at 200 milligrams daily. In this trial, patients with relapse refractory peripheral T-cell lymphoma with at least one prior line of therapy were eligible and enrolled. They enrolled 133 patients who went on to receive valmetastat at 200 milligrams daily. So it's an oral agent and it's continued in 28-day cycles until progression or unacceptable toxicity. And the primary endpoint of this pivotal trial was overall response rate. So here are the patient characteristics: 133 patients, pretty typical patient population with, 1, 2, 3 prior lines of therapy. Some patients had had prior stem cell transplant. And there are a variety of T-cell histologies, including angioimmunoblastic T-cell lymphoma, PTCL with T follicular helper phenotype, PTCL NOS, anaplastic large cell, and then some of the more rare subtypes. So based on PET imaging, overall response rate is 52%, with a complete response rate of 27%. Pretty good for relapsed T-cell lymphoma, just taking an oral agent. Durations were reasonably durable. Median duration is 12 months. Median progression-free survival is 5 months. And there was some differential response based on the T-cell subtype. The numbers are small here, but you can see that it looks like angioimmunoblastic would be more likely to respond than, say, an ALCL patient or a PTCL NOS patient. So interesting observations, and it'll be great to see longer-term follow-up on the durability based on the subtype. As far as toxicity goes, pretty well tolerated. The drug definitely causes significant cytopenias, with the most common being thrombocytopenia, some anemia. You can get some GI effects, but those are usually mild. So sometimes the drug would have to be held or dose reduced or interrupted for the thrombocytopenia. But in talking to the investigators, this was very manageable. So I thought this was great looking data and gives me some hope that we're going to have a new effective therapy available in relapsed T-cell lymphoma, where we definitely have a lack of good treatments. And then the last one I wanted to mention was this drug, galidositinib. And this is another study in relapsed peripheral T-cell lymphoma using an oral JAK inhibitor, JAK1 inhibitor. So same logic as the last trial, a lack of good treatments in relapsed T-cell lymphoma. There's fairly high frequency of JAK and JAK-STAT mutations in T-cell lymphomas, and these can be activating mutations. And so that's some of the logic for trying a JAK1 inhibitor in relapsed peripheral T-cell lymphoma. So this trial is designed a lot like the one I just showed you. Patients need to have relapsed peripheral T-cell lymphoma. And if they did, they were eligible to receive galidositinib at 150 milligrams daily. Cycles were defined as 21 days. And the overall, or the primary endpoint here is overall response rate. Here are the patient characteristics, so just over 100 patients enrolled, median age 58, and then here are the different T-cell histologies over here. So this trial had more PTCL NOS patients and a smaller number of AITL patients and ALCL patients, etc. Overall response rate came in at an impressive 44%, with 24% being complete responses. So really, I thought for an oral agent in relapsed T-cell lymphoma, this was pretty darn good. This just gives you some sense of the durability. So PR is not terribly durable. Here's the response duration for all patients, and if patients were lucky enough to achieve a CR, they had, more potential for durability. Median duration of response was 20 months. So I was impressed with what we saw there. Safety looks pretty good. Similar to the EZH2 inhibitor, there's a lot of thrombocytopenia with the drug, including some grade 3. And they also saw some neutropenia, so there would sometimes need to be dose interruptions or dose reductions because of cytopenias. But overall, I thought the safety profile looked acceptable in this very high-risk patient population. So I thought those were two really interesting and encouraging data sets for relapsed T-cell lymphoma, and hopefully those two drugs become available for general use soon in relapsed refractory peripheral T-cell lymphoma. So there's my my pick for ASH abstracts that I thought were of some interest from the 2023 American Society of Hematology meetings. And at this point, I'll stop the presentation. I'd be happy to take a few questions.
Thank you so much, sir, for that wonderful update. It was wonderful. Thank you so much for being with us, sir. And I now request all our discussants to please put the raise hand sign so that we can start our question for Professor Pradkal. Yes, Dr. Harshmukh Ballad, your question, please.
Yeah, thank you for this is regarding CLL fixed duration treatment with rutinib and venetoclax. Any comment on toxicity, particular for venetoclax?
Right. So
Am I audible?
If I heard you correctly, the question was to comment on toxicity for ibrutinib plus venetoclax combination therapy.
Yes, sir.
Yeah, correct.
Yeah, there's definitely more toxicity with ibrutinib venetoclax compared to, say, ibrutinib alone, but it's not a lot more. It's similar to what I showed you in the simpatico trial with mantle cell lymphoma. There's a little more risk for cytopenias with the addition of venetoclax, and there's a little more risk for GI toxicity like nausea or diarrhea. But I've participated in a number of studies where we've given ibrutinib plus venetoclax, and I would say most patients tolerate it just fine. But you will have a few patients, maybe 2 out of 10 or 3 out of 10, where the combination is difficult for them. And I found that if I just dose reduce the venetoclax from, say, maybe 400 to 200, that usually takes care of the toxicities.
Any other question, Dr. Dr. Harshmukh, any other question? Okay. So,
yeah, I'm Dr. Narendra. Can I ask a
yes, sir.
question?
Please go ahead, sir.
Hello, Dr. Brad Carl. It's very nice to see and hear your lecture. There's a small question, probably it's not related to the lecture fully, but there's a small question on double hit lymphoma. So may I know if you use any targeted therapy other than rituximab upfront and in first salvage for double hit lymphomas?
At the moment, most folks in the US are still managing double hit lymphomas with rituximab combined with the dose-adjusted EPOCH regimen, without the addition of any targeted agents. We did do a trial in the US where we attempted to add venetoclax to dose-adjusted EPOCH rituximab, and unfortunately it led to excessive toxicity. And so it really didn't improve outcomes. So that's still an area of big need in lymphoma world.
And in first salvage, suppose we have failed our dose-adjusted EPOCH, what next? What is your practice? I mean,
Well, if the patient fails within 12 months of their first-line therapy, we can then administer CAR T-cell therapy in the US based on our approvals. If the patient has relapsed more than 12 months and they're of transplant age, then we would try a stem cell transplant strategy. And if that failed, then they can go to CAR T-cell therapy. And then if the patient, fails CAR therapy, or maybe they're just too frail for that, then we're looking for a clinical trial option. Or I think now we have approval of both epcoritamab and glofitamab. So we have two bispecifics approved. And so that would be another consideration for a relapsed double hit patient.
thank you, sir. Thank you very much.
Thank you, Dr. Narendra. So there are questions related to hepatosplenic gamma delta T cell lymphoma. Any new abstracts regarding hepatosplenic gamma delta T cell lymphoma? Number one. And what is your current way of management of hepatosplenic gamma delta T cell lymphomas?
Oh boy. Yeah, I did not see any new updates at ASH on management of that entity. And I don't think we have a really good strategy for that entity. I've seen some attempts at administration of like ice and auto transplant. I've seen the SMILE regimen attempted, but I'm afraid I don't think I have any pearls of wisdom on the best management of that entity. We struggle with that quite a bit.
Thank you, sir. So there is another question related to mantle cell lymphoma. In the show called Triangle Study, which shows wonderful results with ibrutinib plus venetoclax plus rituximab, are the days of autologous stem cell transplant gone now in 2024?
That's a great question. I think yes, the days of stem cell transplant are about to end. We saw the triangle presentation a year ago, and I have not adopted the triangle strategy yet, but I've just been waiting for the publication. I just wanted to see the paper peer-reviewed and in print before I change my practice. My understanding is the paper is going to come out any day, literally any day. I mean, for all I know, it came out yesterday and I just don't know it yet. So what I've been telling people is once I get a chance to view the paper, and assuming there's no surprises in it, then I do envision myself moving toward a triangle type strategy in frontline and moving away from stem cell transplantation. So I do think triangle is changing the standard in mantle cell.
There is one question which has come from Dr. Panda. Any role of decitabine in relapsed refractory DLBCL? As there are few papers, but with limited numbers, what's your experience?
Yeah, decitabine. I'm trying to picture data I've seen there, and I'm sort of drawing a blank right now. I think the single agent data shows very low response rates, but I could see it being useful in combination because of its epigenetic effects. We have some studies in the US where we're trying to combine oral azacitidine with standard therapy. We have a T cell study that we're doing that, and we have an elderly diffuse large B cell study, and these are randomized studies. So I think the idea of giving epigenetic modifying agents, hypomethylating agents with standard therapy is being tested in randomized clinical trials right now as we speak. We don't have the data yet.
Thank you, sir. Another question from Dr. Rina Nair, role of azacitidine plus len in T-cell lymphoma relapse refractory.
Azacitidine plus len. Yeah, I think the response rate to single agent len is in the 20 to 25% range. And I think I've seen a little bit of data with that combination. Small numbers, though. It's not a strategy that I've used off of a clinical trial, but I do think it's a perfectly reasonable combination if you don't have access to other agents or you don't have a clinical trial. We all know managing relapsed T-cell lymphoma can be very difficult, and you can run out of options very quickly. So I do think that combination is perfectly reasonable to try.
Thank you, sir. Another question from Dr. Rina Nair, ma'am. A role of ibrutinib maintenance along with rituximab post autologous stem cell transplant in mantle cell lymphoma.
Right. So that really gets to what we were just talking about with the triangle data. So yes, I do think that is becoming the new standard. And so what I will offer once triangle is published, what I will offer patients is after they complete their induction therapy, no stem cell transplant, and then just move on to maintenance rituximab, plan to give that for 3 years. And then in Triangle, they gave the BTK inhibitor for 2 years. So that's what I envision doing, is just following that recipe that they did in Triangle. I do plan to stop the BTK inhibitor after 2 years and not, continue it indefinitely, just as they did in Triangle.
Thank you, sir. So, sir, according to this triangle data, where are we supposed to give chemotherapy in mantle cell lymphoma? For example, patient has got very high risk mantle cell lymphoma with a very high Ki67 or SOX11 positive. Are we justified to go for chemo first, followed by autologous stem cell transplant and then maintenance ibrutinib? Versus those who are SOX11 negative, Ki67 low, not of blastoid variety.
I think I'm trying to think how to give this answer concisely. I think if the patient, it depends how you define high risk mantle cell lymphoma. If the patient has P53 mutation, then chemotherapy just is very ineffective. And you should try just to go to novel agents. So to me, that's its own little bucket in mantle cell lymphoma. That's very different than, say, having a high Ki67, but no 53 mutation. So having high Ki67 is bad, but it doesn't mean chemo won't work. Chemo can still work here. So if it's just very proliferative, I still use my normal approaches. I'm worried about that patient, but we don't know that abandoning chemo is the right thing to do in the highly proliferative cases. Like if you look at data for novel agents in highly proliferative mantle cell, they don't work as well there either. So I think the idea of abandoning chemo right now, the data shows, yes, abandon chemo in P53 mutated, but for all other high-risk mantle cell, I still use traditional approaches. I hope that answered the question.
Yes, sir. Thank you. Dr. Mohammad Rifai has a question. How will you proceed for relapsed PTCL with TFH phenotype post 2 lines with CHOP and MIND treated? And patient is CD30 positive, which is scattered.
Well, is the patient young enough to be considered for transplant? And that would be a strategy. If not, maybe CD30 based therapy like brentuximab vedotin. I have to admit I don't know what agents are available to you in India, so I'm afraid I could give you an answer, but it might be a drug that you don't have access to.
Rituximab is available, sir.
Yeah.
Thank you, sir. Dr. Kunal, you have a question?
Good afternoon, good evening, sir. So we have a patient, 36-year male. He's a case diagnosed as CLL bulky disease in 2020, and he has translocation, IGS translocation and ATM deletion in 82% of the cells. He received 6 cycles of RCVP and 4 cycles of R-CHOP, but there was no response. Then he came to us and we have started on ibrutinib since 2021. He is doing well. He has a mass sibling donor. So according to you, what should be doing? I mean, whether we should continue ibrutinib, go for transplant, or ibrutinib with venetoclax?
I think, and he's doing well on ibrutinib right now.
Yes.
I would just continue single agent ibrutinib. I wouldn't add venetoclax. I would just give single agent ibrutinib as long as I could. I would not refer that patient for allotransplant until they've failed a BTK inhibitor and a BCL2 inhibitor, just because of the risks associated with allotransplant. And allotransplant doesn't work that great in CLL, a lot of relapses, a lot of morbidity. So for me personally, I would just use ibrutinib as long as I could. And if and when that fails, I'd go to, a BCL2 inhibitor, and I would only go to allotransplant when the patient has failed both of those.
Okay. Thank you, sir.
Yep.
Thank you, Dr. Kunal. So another question from Dr. Rina Nair. Does the CD30 IC staining have an impact on the outcome of E-cell NHL with brentuximab?
Yeah. We've seen responses even with very low CD30 expression. So you definitely can still get responses even when the CD30 expression is low. My own impression is that the responses aren't quite as robust. They're not as durable. So I think a patient with low CD30 can respond to brentuximab, but I often think the drug it doesn't work as well in those cases. It can still work, but it doesn't work quite as well.
Thank you, sir. Well, I've finished all the questions from the audience. Any discussion wants to ask any other question to Professor Brad Cal? Okay, so there are no raise and signs and no more questions from the audience. So thank you so much. We were fabulous and giving light on the clinical relevant updates on lymphomas. Thank you so much for being with us today. It was a pleasure over here to be over here with you, sir, on board, sir. Thank you so much for being with us today.
Thanks for having me.
Thanks a lot, sir. Thank you so much.